In this lecture, we will discuss acute and infectious respiratory illnesses in children. This will be a generalized overview of the different diagnoses, as there are several to know. On completion of this lecture, and after finishing the required readings, you should be able to describe the etiology and pathophysiology of common acute respiratory illnesses in children, explain the clinical manifestations of common acute respiratory illnesses in children, compare and contrast nursing interventions and treatments associated with common respiratory illnesses based upon causative infectious organism, and outline important teaching points for caregivers to care for the pediatric patient with respiratory illness at home. The following slides will detail findings, risk factors, and care for general viral respiratory illnesses in children. We will then break down individual illnesses and considerations for each. Infants between 3 to 6 months of age are at an increased risk of acquiring viral illnesses. This is due to a decreased amount of maternal antibodies and the lack of antibody protection. Additionally, toddlers and preschool-age children are at an increased risk for viral illness due to their anatomy, which is compounded by increased exposure to other potentially ill children, typically in daycare and preschool settings. Infants and young children have short, narrow airways that are easily obstructed with an accumulation of mucus and swelling. They also have shorter respiratory tracts, which allow pathogens to quickly travel to the lower airways. Children who have a compromised immune system, anemia, nutritional deficiencies, allergies, chronic medical conditions, and exposure to smoke are at an increased risk of acquiring infections. Wintertime, cold weather, and significant changes in the weather can lend themselves to respiratory infections. Respiratory viral illnesses in infants and children are generally characterized by sore throat, a decrease in activity and fatigue, chest pain, difficulty breathing, shortness of breath, cough, and a decrease in appetite. To diagnose suspected respiratory illnesses, a throat culture can be obtained to rule out strep throat. Rapid antigen testing can be performed to identify the viral origin, or polymerase chain reaction assays, called PCRs, can be used to more accurately identify viral causation. When caring for a patient with respiratory illness, you will need to monitor for respiratory distress. So watch for increased respiratory rate, retractions, nasal flaring, head bobbing, restlessness, etc. You want to position them for optimal ventilation. Place them on isolation precautions as indicated. So if a viral infection is confirmed, contact droplet precautions are typically recommended. Prepare for intubation should that be or become indicated at any point for respiratory distress. Caregivers need to be educated on how to care for their child with a viral illness, both in the hospital and out. First and foremost, we want to encourage them to reduce the spread of illness and infection. This includes performing hand hygiene, covering the nose and mouth when coughing or sneezing, avoid sharing cups, utensils, and food, and ensuring that those who are ill stay home when sick. You will notice in much of this lecture that illnesses that are viral require supportive care. Patients need adequate fluid intake and rest. This can mean that infants need supplemental fluids with electrolytes, such as Pedialyte, and that older children may need sports drinks or electrolyte supplements. We can suggest cool humidification as an intervention to improve comfort. And caregivers need information on when to seek medical care, namely recognizing respiratory distress or worsening symptoms. Children with respiratory illnesses are at risk of secondary bacterial infections due to a buildup of mucus and damage to the mucosa. As you can see in the image up top, the respiratory tract for infants and children is much smaller than that of older children and adults. Otitis media is also common after viral or bacterial respiratory infections. In the bottom image, you can see that the eustachian tube in children is much shorter and flatter than that of adults and older kids. This allows for a buildup of fluid to infect the inner ear space. Sinusitis and pneumonia are also common secondary bacterial infections. Nasopharyngitis, also known as the common cold, is a self-limiting virus that lasts anywhere from 4 to 10 days. Symptoms of nasopharyngitis include nasal inflammation, dryness and irritation, fever, decreased appetite, and restlessness. Care for nasopharyngitis, much like previously discussed, is supportive. Antipyretics can be administered to treat fever. The patient should get adequate rest, and cool humidification can be provided for comfort. Generally, in young children, we aim to avoid anticongestants, cough suppressants, and antihistamines due to undesired side effects they can cause. In viral illnesses, antibiotics are not indicated and should be avoided. Influenza is a common illness, especially in the winter months, that can affect children and adults alike. In children, the symptoms can range from mild to severe. You may see a sudden onset of fever and chills, dry throat and nose, a dry cough, flushed face, photophobia, myalgia, and fatigue. To diagnose influenza, a PCR or fluorescent antibody test can confirm the infection by the influenza virus. Supportive care is necessary, but there are also a few antiviral medications that can be prescribed. First is amantadine, which must be given within 1 to 2 days of onset and shortens the duration of symptoms. Amantadine treats symptoms and is given twice a day for 7 days in kids older than 1 year. Zanamivir can be used to treat kids over 7 years old or prophylactically for kids over 5. It is administered via inhalation twice a day for 5 days and must be initiated within 2 days of onset. Oseltamivir must also be given within 2 days of onset for 5 days and is an oral medication that's used to decrease symptoms for kids over 1 year. To prevent influenza infections, it is recommended that children 6 months and older are vaccinated yearly. There are inactivated or live options of the vaccine, and appropriate caution should be taken if a child is to receive a live vaccine. Live vaccines should be avoided for anyone with immunocompromise, an allergy to eggs, or a history of Guillain-Barré. Bronchiolitis results from a viral infection, typically respiratory syncytial virus, or RSV, which causes the small airways, called bronchioles, to become swollen and filled with mucus. Bronchiolitis is a significant cause of hospitalization for infants, especially during the winter months, and can be severe. Symptoms typically last anywhere from a week to a month and can progress in severity. Initially, you may see rhinorrhea, low-grade fever, pharyngitis, coughing, sneezing, wheezing, or ear and eye infections. As the illness progressively becomes more severe, you'll see copious secretions that contribute to decreased feeding, thus dehydration, and progressively worsening respiratory symptoms. You may see tachypnea, retractions, apnea, poor air exchange, poor breath sounds, and cyanosis as a result. Bronchiolitis is primarily diagnosed by symptoms and history, but to confirm a viral causation, a PCR or RSV antigen detection test can be used. Care, again, will be supportive. On the next slide, we'll talk more about the American Academy of Pediatric practice guideline recommendations regarding diagnostic testing, interventions, and monitoring. Supplemental oxygen and pulse ox monitoring can be used if indicated. Otherwise, fluid intake and breastfeeding are recommended. We want to maintain a patent airway, suction as needed, but medications are not typically recommended for treatment. The American Academy of Pediatrics outlines recommendations for diagnostic testing, medications, treatments, and monitoring for patients with bronchiolitis. When we think about diagnostic testing, we always want to consider, will this change our plan of care? In the case of bronchiolitis, the answer will typically be no. Diagnosis is typically made based on symptoms, so lab testing and cultures are not recommended except in the cases of infants less than 12 weeks old and children with known comorbidities. Chest x-rays are not recommended, as we know to expect that there will probably be some patchy consolidations. Again, it's not likely to change our plan of care at this point. A respiratory viral panel by PCR can be used to confirm a viral pathogen, but is not necessary to guide treatment. As mentioned previously, care for respiratory illnesses is supportive. Albuterol and inhaled epinephrine are no longer recommended for single-use trials, but historically have been trialed in kids with known history of asthma or reactive airway disease. Corticosteroids and chest physiotherapy have not been proven to improve outcomes, therefore are not recommended. Antibiotics are not indicated, as bronchiolitis is most commonly caused by a virus. Deep suctioning or nasopharyngeal suctioning is not recommended and has been linked to increased length of stay. The guideline does not specifically reference cough suppressant or decongestant use. However, in my practice, these agents are also not recommended. We want to encourage the patient to cough so that they're able to clear their airways of mucus. With cough suppressants, you must also be cautious of side effects as they usually have multiple medications within them. Decongestants, on the other hand, can cause a rebound effect, meaning that they may help at first by constricting the vessels, but then vessels overdilate and produce even more mucus. If a patient with bronchiolitis has no known risk factors and does not require oxygen therapy, the bronchiolitis guideline does not suggest continuous monitoring of SpO2. Patients with hypoxia who have no known risk factors can use continuous or spot check oximetry. Those with hypoxia and risk factors should be on continuous pulse ox and CAM monitoring for 24 hours, which can then be discontinued if no apneic spells are noted. Continuous pulse ox has been linked to longer length of stay and increased costs in the bronchiolytic population. Pulse oximetry is also not a super reliable indicator of respiratory distress. Normal, healthy infants have been found to have transient desaturations when on continuous monitoring, which supports the statement that continuous pulse ox should only be used when clinically indicated. Frequent respiratory assessments can be used to help identify an infant's response to treatment. Patients with bronchiolitis are typically going to use a heated high-flow nasal cannula setup, which is pictured here. Heated high flow is initiated for infants who require greater than 2 liters on nasal cannula. Heated high flow allows for titration of flow and FiO2 to address an infant's work of breathing and hypoxia. It uses a warm humidification setup. The O2 flow meter, circled in green, is titrated in response to a patient's work of breathing. The FiO2 blender, circled in purple, is adjusted in response to a patient's saturations on pulse oximetry. If a patient is working harder to breathe, the nurse or respiratory therapist would increase the flow on the O2 flow meter. If a patient is desatting on pulse oximetry, the nurse or RT would increase the percentage of FiO2 given on the blender. The same can be said of the reverse when weaning. If a patient's work of breathing has stabilized, the clinician could turn down the flow on the O2 flow meter. If the patient has stable, consistently high saturations on pulse oximetry, the clinician could then decrease the amount of FiO2 on the blender. Once a patient has reached 3 liters and 30% on heated high-flow nasal cannula, a room air trial can be initiated. Let's test your understanding with some practice questions on the next 2 slides. Allergic rhinitis is a self-limiting seasonal reaction to allergens. It is most common in the spring or fall when weather changes the most. Symptoms include watery rhinorrhea, nasal obstruction, itchiness of the eyes, nose, and throat, snoring, fatigue or malaise, headache, and poor school performance. To diagnose allergic rhinitis, a nasal smear to identify eosinophil count or an immunoglobulin blood test to detect IgE can be used. Additionally, allergy skin tests can be administered to determine specific allergen triggers. Caring for a patient with allergic rhinitis requires home management education. This includes instructing the caregiver and patient to avoid allergens, utilize nasal corticosteroids like fluticasone, and use other medications like antihistamines, decongestants, mast cell stabilizers, leukotriene modifiers, and/or ipratropium as prescribed. There are two types of croup, one called acute laryngotracheobronchitis and the other acute spasmodic laryngitis. The first is caused by a virus, or in some cases Mycoplasma pneumonia, and the latter is caused by allergens or a laryngeal obstruction. Symptoms of croup include a barky cough, restlessness, hoarseness, difficulty breathing, stridor, and in laryngotracheobronchitis, they may have fever or increased work of breathing as well. To care for a patient with croup, the following interventions may be recommended: cool mist humidification, oxygen with pulse oximetry as indicated, racemic epinephrine via a nebulizer, corticosteroids, which can be administered either IM, orally, or nebulized. And we want to encourage adequate fluid intake, whether that be oral intake or via IV fluids if needed. Bronchitis occurs from inflammation of the large airways secondary to an upper respiratory infection. Symptoms include a persistent, dry, hacking cough that usually resolves in about 5 to 10 days. It can be diagnosed with a test of nasopharyngeal secretions. Care includes antipyretics for fever if indicated. Your ATI book recommends cough suppressant, but in younger children, again, not typically would be recommended in the clinical setting, and humidification via a cool mist vaporizer. Now we will switch gears and focus on respiratory illnesses that are primarily caused by bacterial pathogens. Care for these infections in particular will differ from that of the viral illnesses. Bacterial pneumonia is an infection of the lungs that's typically caused by strep pneumonia, group A hemolytic strep, Staphylococcus aureus, Mycoplasma pneumonia, Mycoplasma catarrhalis, or it can be viral in origin. Symptoms typically include a high fever, a cough, which can either be unproductive or productive with a white sputum, tachypnea, retractions, nasal flaring, chest pain, dullness on percussion, adventitious breath sounds like crackles or rhonchi, pale color, cyanosis, irritability, restlessness, and lethargy, and even abdominal pain, diarrhea, lack of appetite, and vomiting. To diagnose pneumonia, a chest X-ray is usually the test of choice, and it will identify any infiltrates. Gram stain or sputum cultures can be obtained, as well as nasopharyngeal cultures and blood cultures. A lung aspiration or biopsy may be indicated, and if a strep infection is suspected, an anti-streptolysin titer. Treatment for pneumonia will include encouraging rest, monitoring intake and output with an increased PO intake, particularly of fluids, CPT with postural drainage, administration of IV fluids if necessary, oxygen with pulse oximetry if indicated for saturations and workup breathing, and administration of IV antibiotics, which will be guided by the results of the cultures obtained. Some complications that can occur with pneumonia are pneumothorax and pleural effusion. Pneumothorax is the accumulation of air in the pleural space, while pleural effusion is an accumulation of fluid in the pleural space. Both complications will have symptoms of dyspnea, chest and back pain, labored breathing, decreased oxygen saturations, and tachycardia. To treat both complications, we would be prepared for a needle aspiration to either remove the air or fluid from the pleural space. This is done with placement of a chest tube to close drainage. We would want to continue assessing our patient's respiratory status and administer oxygen as needed. Epiglottitis is the swelling of the epiglottis, usually caused by Haemophilus influenza and is a medical emergency. Symptoms include an absent cough, drooling, agitation and restlessness, patients sitting upright with their chin pointed out, mouth open, and tongue protruding, dysphonia, so difficulty speaking, dysphagia, difficulty swallowing, inspiratory stridor, suprasternal and substernal retractions, sore throat, and a high fever. To diagnose epiglottitis, we will use a lateral neck X-ray. When caring for a patient with epiglottitis, we want to ensure their airway is protected, and we should be prepared to intubate at any point. Avoid obtaining any throat cultures or sticking anything into the mouth like a tongue blade. We can provide humidified oxygen with pulse oximetry, administer corticosteroids and IV fluids, administer antibiotics via IV, which then can be transitioned to oral antibiotics to ensure a full 10-day course. And we want to initiate droplet precautions for at least 24 hours after initiation of IV antibiotics. We've seen a decline in epiglottitis as a result of the Hib vaccination. Tonsillitis is defined as swelling of the tonsils. Tonsils filter pathogens in the mouth and nose to protect the respiratory and GI tracts from infection. Palatine tonsils are what you probably traditionally think of as tonsils and are found in the back of the throat. Pharyngeal tonsils, also called adenoids, are in the back of the nasal passage, which you can see on the image. Enlarged tonsils can cause problems with sleeping, breathing, nasal and sinus drainage, swallowing, speaking, and can contribute to recurrent otitis media, thus also contributing to hearing concerns. Acute tonsillitis refers to inflamed and reddened tonsils, which can be caused when the tonsils are exposed to a viral or bacterial organism. Risk factors include exposure to viral or bacterial agents and young children with immature immune systems. Symptoms typically include sore throat, difficulty swallowing, mouth odor, mouth breathing, snoring, a nasal quality to the voice, fever, and tonsillar enlargement with redness and swelling. Tonsillitis can be diagnosed with a throat culture. Group A beta hemolytic streptococcus is a common cause of tonsillitis. It has an abrupt onset, and symptoms include sore throat, headache, fever, and abdominal pain. The tonsils and pharynx are inflamed with an exudate that usually appears the second day of illness. Strep throat, like other bacterial tonsillitis, is treated with antibiotics, which can be oral or IM, and antipyretics for fever. Other nursing interventions may include encouraging rest, warm fluids, and participating in saltwater gargles. Educating caregivers on considerations for medications is important. For antipyretics, we want to teach the appropriate dosing for Tylenol, ibuprofen, and an appropriate schedule for using these. With antibiotic administration, we also want to consider allergies of the patient, discuss common side effects, and teach the caregivers to give the full course of treatment. Patients with chronic tonsillitis or repeated strep throat infections may require a tonsillectomy to remove the tonsils. Patients will be NPO prior to surgery, and after surgery, there are many considerations and interventions to be done by the nurse and caregiver. You want to position the patient to facilitate drainage, raising the head of the bed. You also want to consistently assess for bleeding. Signs of bleeding can include frequent swallowing, coughing up blood or clots, bright red emesis, tachycardia, restlessness, and pallor. You also want to assess the patient's airway to ensure it is patent and continuously monitor their vital signs. Comfort measures post-tonsillectomy are also extremely important. We want to administer liquid analgesics and pain medications. Typically, we don't recommend opioids for pain management in children. You can also provide ice chips, cold drinks, popsicles, and ice cream to help keep the throat moist and numb. You can advance from a clear to a regular diet after surgery, encouraging soft foods. We want to avoid any red foods or dyes, avoid spicy, acidic, or milk-based foods, avoid blowing the nose, clearing the throat, or coughing excessively, and avoid the use of straws as it can damage the surgical site. On discharge, caregivers should be educated on how to care for their patient at home. This includes information about proper diet and hydration status, how to stick to a consistent pain management schedule. When they initially go home, we recommend that for at least the first 3 days, they're receiving around-the-clock pain medication with Tylenol and ibuprofen alternating, and then they can start to space those out. We want them to also wake up their child overnight so that the patient isn't waking up in the morning in a lot of pain, which can then contribute to dehydration down the road. We also want parents to know the signs to monitor for bleeding as well. We want them to know that their child shouldn't be putting things in their mouth. We want them to avoid strenuous activity and exercise until after the child has made a full recovery, which can take up to 2 weeks. And then they also need to know when to call the doctor or proceed to the ER. So that would be unexpected bleeding, signs of dehydration, if the patient has uncontrolled pain, or if there are any signs of infection. Complications with tonsillectomy include hemorrhage. So we would want to assess the throat area for any local signs of bleeding, and then we also want to assess the patient for systemic signs of bleeding. Dehydration is another complication. So this usually occurs from decreased PO intake secondary to uncontrolled pain. So we want to stay ahead of pain and consider admission or IV fluids if dehydration gets severe enough. Chronic infection is also a complication with tonsillitis in general. So repeated strep infections can increase the risk of rheumatic fever and kidney infections. So caregivers should seek treatment for any signs of tonsillitis or any signs of infection following the tonsillectomy. Finally, key takeaways from this presentation. You should know that infants and young children are especially susceptible to respiratory illnesses. Pediatric anatomy increases the risk of secondary bacterial infections, and that the care for respiratory viral illnesses is supportive. Please reach out if you have any additional questions regarding this information.